All right, hey ho, let's go. This is Resistance Radio, where natural selection selects resistance and power selects who gets protected. So, you know how this works. A new outbreak hits, reporters call it tragic, politicians call it unpredictable, and somehow, people who end up the sickest were already living on the margins before the virus ever arrived. That's not a coincidence, that's a policy decision. Today, we're going to talk about what's happening right now in global and domestic public health, not just the pathogens, but the politics behind them. Because the thing about public health is this: it is fundamentally a statement about whose lives we decided matter enough to protect systematically. So let's start in the Ituri province of the Democratic Republic of the Congo. Let's get an update there. As we know, there's an active declared public health emergency of international concern for Ebola, specifically the Bundibugyo strain, a less commonly studied cousin of the Zaire strain that you know about from the 2014-2015 Ebola outbreak in West Africa. Now, as of late May, early June, we're looking at over 900 suspected cases and more than 200 suspected deaths. Again, that puts us at about a 25% case fatality rate. We have 125 confirmed cases in the DRC and at least 9 confirmed cases in Uganda right across the border. That confirmed mortality rates, like I said, sits anywhere between 25%, depending on how the data shake out. To put that in terms that's easier to hold in your mind, if you filled a 747 with the Bundibugyo patients, between 130 and 230 of them would not be walking off that plane. Here's what you need to understand about the Ituri province. The outbreak did not land in a vacuum. The International Committee for Red Cross, Mercy Corps, and Action Aid all describe Ituri as a province already living with chronic armed conflict, food insecurity, mass displacement, and the near total collapse of formal health infrastructure. WHO Director General Tedros himself said on May 25th that Ituri is not only the epicenter of the Ebola outbreak, but also one of the hardest hit areas by acute hunger, and that people weakened by hunger are far more vulnerable to infection. 3 Red Cross volunteers working the response have also already died. And here is the policy dimension that never gets enough airtime. The Bundibugyo strain has no licensed vaccine, no proof-specific therapeutic. Every monoclonal antibody and every vaccine we built after West Africa, they all target the Zaire glycoprotein. They are functionally useless here. Why? Because research investment follows the strain with the biggest prior outbreak footprint, which follows, you guessed it, the strain that scared the wealthy nations the most. The strains that kill only poor and conflicted area populations, they go back to the research bench, and essentially they're on the back burner. When we say there's no vaccine for Bundibugyo, that is not a tragedy of science. That is actually a tragedy of priority setting, or really the lack of. So let's bring this home. Because what's happening in the DRC doesn't exist in isolation from what's happening to the American public health system. And what's happening here is a slow, deliberate, politically motivated demolition. The Trump administration proposed a 53% cut to the CDC's budget for the fiscal year of 2026. Let that land for a second. The single agency responsible for tracking outbreaks, issuing clinician alerts, coordinating laboratory capacity, and running national immunization programs on the table for more than a 50% funding reduction. But it doesn't stop there. In February, the administration moved to terminate approximately $600 million in CDC grants to 4 states: California, Colorado, Illinois, and Minnesota. The rationale behind this was delivered in writing, and that was that these grants do not reflect agency priorities. The programs affected HIV surveillance, HIV prevention, PrEP access, injury prevention, workforce development, behavioral health risk surveillance, and public health data modernization. Programs serving, by definition, the people most likely to fall through the cracks: people living with HIV, the LGBT communities, low-income families, people in substance use recovery. A federal judge temporarily halted the cuts after four state attorneys general filed suit, with the judge finding the states would suffer, in his words, irreparable harm. Then there's the Health Alert Network, the CDC system for pushing urgent clinical advisories to frontline physicians and public health officials when a new or emerging threat requires action. NPR reported earlier this year that the CDC has significantly curtailed the number of health alert networks issued since the Trump administration began, leaving clinicians describing themselves as flying blind on emerging threats. The health alerts, these are not glamorous. No one writes magazine profiles about it. But when Bung de Bung Ju Ebola walks off of a plane, or when a novel adulterant enters the drug supply, the HAN is what stands between clinical near miss and a catastrophic outbreak amplification event. Silence from public health agencies is not neutrality. It's a choice with body count consequences. All right, so let's move over to vaccine rollbacks in children who will pay for it. In January of 2026, federal officials quietly overhauled U.S. childhood immunization schedule, removing 6 vaccines from universal routine recommendations, including rotavirus, hepatitis A, hepatitis B, meningococcal vaccine, influenza, and COVID-19, and replacing those recommendations with either quote-unquote high risk only or quote-unquote shared clinical decision-making. Critically, that was done by bypassing the normal ACIP evidence review process, this transparent, public, expert panel-driven system that has underpinned vaccine policy in the country for decades. The American College of Physicians statement on this was clear. This is a fundamental break from evidence-based system the U.S. has relied on for decades, one that puts children at risk. So now the data is arriving. A Yale School of Public Health modeling study warns that if the rotavirus vaccine coverage drops to 60%, pediatric rotavirus hospitalizations over 5 years will more than double, from approximately 36,000 to more than 85,000. If coverage collapses to 20%, that number climbs to roughly 204,000. Think of this as the difference between filling one large children's hospital over 5 years versus 5 or 6 of them repeatedly every year. With kids sick from a disease we've already had the tools to prevent. And who are these children? Not the ones in well-resourced zip codes where engaged parents have a 30-minute shared decision-making conversation with trusted pediatricians, risk-benefit calculus. They are the kids of parents working 2 jobs who didn't get the memo. The kids in under-resourced community health clinics where shared clinical decision-making needs a brochure no one has time to read. The kids of parents who speak limited English and for whom a change in a recommendation signals that maybe the vaccine was never safe to begin with. The burden of ambiguity in public health policy is never distributed evenly. It always lands hardest on the people who are already carrying the most weight. So finally, measles is back. This time, it came back with some help. At the same time, now the U.S. is approaching 2,000 measles cases in 2026, with the Pan American Health Organization, PAHO, issuing epidemiologic alert for the entire Americas region on May 29th, warning of resurgent transmission and urgent closure of MMR gaps, that's measles, mumps, rubella vaccine coverage gaps. Meanwhile, a new PNAS modeling study projects that declining MMR coverage poses a substantial public health and economic threat to the U.S. And trust in federal childhood vaccine recommendations has dropped from 71% to 60% in under a year, with the steepest decline among people who used to trust the CDC the most. The AAP is now more trusted than CDC on childhood vaccines by a significant margin. That's the American Academy of Pediatrics. We built decades of herd immunity against measles. We did it through consistent, evidence-grounded, institutional communication. And in less than 1 year of policy chaos, we've watched that trust erode faster than any misinformation campaign could have done it on its own. when institutions that are supposed to protect the public health become politically weaponized, when they become tools of an administration's ideological priorities rather than stewards of the public health, they just don't fail, they actively harm. So, what ties all this together? What do I want you to carry into your week? Understand that public health is not a technical project. It is a moral and political one. Every outbreak we fail to contain, every vaccine program we quietly gut, every data system we defund, every alert we don't send, these are decisions made by people with power on behalf of an agenda that does not include you and certainly doesn't include the kid in Ituri who's sick with a hemorrhagic fever or for which the world choose not to develop a vaccine, or the kid in an under-resourced clinic in Chicago or here in New Orleans who won't be getting a rotavirus vaccine this fall because a policy changed. No one told their parents why. Public health fails when power stops looking out for the whole. It always fails the same people first. This is Resistance Radio. So stay in the fight, stay in the data. And remember, the most dangerous comorbidity isn't obesity or diabetes. It's being poor and politically inconvenient. Until next time, diagnose the system, not just the patient. Thank you. My name is Mark Allen Derry, and this is Resistance Radio.